The University of Alaska Anchorage is excited to announce our third annual UA Giving Day, starting on February 22nd, 2023. We are celebrating 49 hours for Alaska. We invite our community to show your Seawolf pride and to make a difference by making a donation on February 22nd and 23rd to support a program or area that you care about at UAA. To get involved, go to givingday.alaska.edu/UAA and make your donation on Giving Day. Follow our UAA social media pages and share about Giving Day using hashtag 49hoursforalaska. Thank you.
From the University of Alaska Anchorage, this is Seawolf Voices, a podcast about the pathways to and from education. I'm your host, Matt Jardin. Dial 911 and the responding dispatcher might send one of three options: a police officer, a firefighter, or an EMT. But what if no crime has been committed, no laws broken? What if there's no actual burning building, just the feeling that everything is on fire? What if the medical emergency isn't of the body, but of the mind? Enter a fourth option, Anchorage's Mobile Crisis Team. Launched in summer 2021 and housed within the Anchorage Fire Department, the Mobile Crisis Team responds specifically to mental health emergency calls, such as suicidal ideations, schizophrenic or bipolar episodes, and even feelings of grief or loss. Funded by $1.5 million from a 2020 alcohol tax in Anchorage, the Mobile Crisis Team includes 2 units operating 10 hours a day, 7 days a week. Each unit comprises a licensed clinician and a paramedic. The earliest of these units consists of clinician Jennifer Pierce, a clinical psychology alumna, and paramedic Michael Riley, a fire service administration alumnus. In this episode, Jennifer and Michael talk about their respective backgrounds as a police officer and firefighter, what sets the Mobile Crisis Team apart from other emergency first responders, and how they hope the program will grow in the future. Jennifer and Michael, thank you both so much for being on the podcast today.
Absolutely.
Yeah, thank you.
This first question might say a lot about me and just how bad I am at keeping up with the news, but I didn't discover that there was a Mobile Crisis Team here in Anchorage until very recently. But then I did some digging and found out that you guys were announced back in, I believe it was fall of 2020, and then you launched last year, summer 2021. So for listeners who are also like me and bad at keeping up with local current events, can you just tell us what is the Mobile Crisis Team and what both of your roles are in it?
So the Mobile Crisis Team is made as part of a Crisis Now continuum that's coming to Alaska for changing how we respond to mental health crises in Alaska, because that is something in our mental health system that's really missing. And so the Mental Health Trust and the state of Alaska and a lot of different partners, South Central Foundation, Providence here in Anchorage, have been really looking at how can we respond to mental health crises in the community in a different way. And so we are just a portion of that. So it starts with having the call center, 988, mobile crisis teams, stabilization centers, which are up and coming. And so the Mobile Crisis Team, we respond to behavioral health crises in the community. And what we bring from the fire department, which is so great that we're part of the fire department, is we're part of the emergency response system already. And so we can be integrated in very easily between police and medical crises and fire. And so having the Mobile Crisis Team is made up of a licensed mental health clinician right now and a paramedic. And so we bring integrated healthcare to the community, to individuals that are having more of a behavioral health crisis, trying to determine, is this purely a mental health crisis and they're needing help, or is this also a medical crisis, or is this both? Mm-hmm. Right? And so we can really work together in finding, what is the best outcome and working with the individual in the community. So that's, we try to divert away from the emergency rooms when we can. Mm-hmm. And we also try to help people stay in the community where they are safely to have better outcomes and actually get people connected to the resources that they really need. And for my role, I am the licensed mental health clinician on the team, and we respond with our paramedics, and I'll let Mike take it over from there.
Yeah, so that's what Jen was saying about it being an integrated response. That's really the power in it, the synergy in it, is because Jen brings a perspective that the first responders haven't had before. Bringing her experience as a licensed clinician with that advanced training, her lens looks different. For the most part, these are the same calls that police and fire are going on today. We're just an additional resource, a better option for these crises. And so she brings a training in a lens that I don't have. And so when we show up together, I look through it through the lens of a paramedic. Is this a medical emergency? Are they stable? Are they safe? And then once we kind of determine that this is not a medical emergency, but this may be more behavioral, then that's when the clinician can kind of step in. We do it together, do have some of the same training, but they're far more advanced than we are, right? But we work together as a team and kind of take different approaches and see who's getting along with that person as well. Sometimes I get along better, sometimes Jen may get along better, most of the time Jen does. But it's just really good because it's nice for Jen, because she can rely on me and say, okay, I know Mike has done an assessment of this person. I know this is now more behavioral, not medical, and now I'm comfortable with proceeding with the therapeutic interventions that I have, right? And so that's just a synergy in it. And that's where, as a paramedic, I always felt like there was something missing. Like I felt like I didn't have the ability to help de-escalate somebody or to help motivate somebody to go to the hospital when they actually need to go because they're depressed or sick or something like that. I didn't have de-escalation when they were really amped up and yelling and screaming and really upset. I didn't know how to ground them or bring them down when they were, when they weren't doing well. And so it's just really nice to have a clinician along for that and that's just a synergy in it that just, we come at it from both angles and it really meets the person where they're at.
Sometimes I feel like the Swiss Army knife of clinicians, though.
Yeah.
Because it's any age. We get asked that a lot. Like we only see adults or something, and we see every age. So children all the way. My youngest that I've seen is like 4 years old, and the oldest we've seen is like 99, 96. So, and it doesn't. All different types of crises. It could be a struggling with problem solving. It could be a panic attack. It could be someone struggling with suicidal ideations. It could be someone struggling with schizophrenia, bipolar, just having grief and loss. It's really anything. It's for anyone, really anywhere. We can respond and help.
How did the mobile crisis team get started, and how did the two of you come to be a part of it?
So I think it was, make sure I have my timeline right, it was fall of 20, August of 20. So sometime in early 20, January, February, early 20, I happened to be in a meeting with an individual from Providence who was a director of behavioral health over there. And I had just read an article about integrating social work students or behavioral health students, master's level students with fire departments to outreach individuals that are utilizing EMS kind of excessively, not getting their needs met. And so I approached her with this idea, and it was really well received. And so over the next kind of, I think 7 months, we kind of developed this concept, because there was a lot of stuff you had to put in place, MOUs, agreements, stuff like this, find out if there's funding needs, is UA even interested, like there's a lot of stuff in the process. But over the next 7 months, we kind of worked on this, and this individual one day just called me up and was like, I found the perfect person. She was former APD, she has her master's, and she's working on her PhD. She's going to be perfect for this. I was like, great, let's meet her, And so, in I think July of 20, we got a chance to meet over Zoom at that time. And yeah, absolutely, like this is going to work, let's do this. And so in August or maybe early September, Jen came and worked on her practicum as a PhD student, so practicum site, and just co-responded with me. So at that time, I was running a program where I was at outreaching, sort of community outreach to high utilizers and helping them kind of get their needs met where they weren't, like the EDs weren't helping meet their needs because maybe it was a more resource or they needed doctors or medications or something. The ED just doesn't have that capacity, right? They're for the emergency, the acute emergencies. And so Jen just started riding along with me, and we just started outreaching the same clients or working with new clients, and it just worked really well. And then that fall, the circumstances were just fell into place. That fall, we got funding from the alcohol tax. I think in November of 20, we found out we received that funding to develop a mobile crisis team. So just Jen already being there was just, it was just serendipitous almost, right? So it was like, absolutely, let's just keep working the same program we're doing, but let's also build this other program together. And so for the next, I think it took us 6 months. So for the next 6 months, we did both, working on program development for the mobile crisis team, maintaining the high healers outreach team. And in July of 20, we went live with a team, with 2 teams, 2 clinicians and 2 paramedics.
So, Jen, you were previously an officer with APD, and Mike, your experience was with the fire department. So what has that transition been like from, APD and from primarily working with the fire department to running this mobile crisis team?
For me, it's been amazing because I kind of touched on it already. The calls that the mobile crisis team was responding to were calls that I was already responding to as a paramedic on an ambulance. But I never felt like I had the right tools. And I never felt like I was part of the solution. I was, for lack of a better term, I was a ride to the hospital. And then it felt like, and this is, just as feelings, but it felt like we were seeing the same people over and over. It felt like they were not staying there very long. They were just going right back in the community, calling us, and they just kind of stayed in this crisis and this recidivism. And it really fatigued you, it's called compassion fatigue. It was hard to stay in the moment and be like, we're here to support you, because it didn't feel like we were. And so having a clinician along and being a unit that is, our sole responsibility is to make sure this person is connected and we have all the time to do it, is just awesome. It's a really big relief. It has kind of restored my hope in this system and really just energized me to just keep doing this good work.
For me, it's been quite a journey, going from being a police officer and having those experiences and then feeling like as a police officer I wasn't actually helping at certain, a lot of times I felt like I wasn't. That's why I became police officers. I really wanted to help people, and I felt like I wasn't doing it. And so through just a lot of different circumstances, I ended up going back to school here and getting my master's in clinical psychology, and then going into the hospital and working there and getting that perspective, right, what it's like to work in a hospital, in the emergency room, and in an inpatient unit. And then bringing all that experience into the field has just been a great journey. And I really appreciate more of bringing that knowledge in as being a police officer, because I can understand how police officers view things and what they're seeing. And then now I feel like I have the time and I have the patience and the skills to actually help someone. And it feels so much more relieving and satisfying at the end of the day to feel like I actually help someone feel a little bit better, or help someone get the needs that they actually needed or the resources that they needed, instead of just kind of throwing your hands up in the air going I don't know what to do. I feel like we can actually help people feel a little bit better, and then also we can communicate individuals and advocate for individuals a little bit better too. I feel like I can also communicate with police officers a little bit better about this is what might be helpful, or this is kind of what's going on. And then we can also communicate better with the emergency room, where I can communicate with clinicians, use their lingo, right, and say the things that's important to them, while Mike can also communicate to the providers, the medical providers, better than I can. I still learn every day about different medical aspects and different important things that's important to communicate with them.
So having that experience and just knowing how to ask the right questions or how to give the right answers to the next people is just incredibly important. Absolutely.
And knowing what information they need, right? Because when I was working as a police officer, I'd bring someone into the emergency room and be like, I don't know, they're having a bad day. And then working as a clinician in the emergency room, I need more information. That's frustrating. And so now, kind of being that first responder, I really hope to help communicate that and provide that warm handoff when someone needs to go to the emergency room, or provide that warm handoff to outpatient providers, right? And helping communicate for the individual and advocate for them, which is so important.
So someone calls 911 and 911 dispatches mobile crisis team. What is that response like, and how is that different from maybe a police officer showing up, or a firefighter showing up, or a visit from the ER?
I think the biggest way to kind of describe it is the lens that which we look through. So when I was a paramedic on an ambulance, my lens was to assess for an acute emergency and treat appropriately, right? So we show up and we say, are you in an acute emergency? Are you having trouble breathing? Is something going on with your heart? Are you bleeding? These are acute things that are going to injure you if they're not done in time, not treated and transported in a timely manner. Kind of once we get past that, my lens kind of gets foggy because I'm not really sure what you're looking for. And I wasn't really trained to really find out what that additional, what they're struggling with, right? And even if I did learn it, I still had one option, was to transport to the hospital or to leave them in the community without resources, right? I didn't know how to connect them. And so for when our team shows up, we have those lenses now, we have those resources, we have those connections. And so we show up and I'm not going to massive bleeding, I'm not going to cardiac arrest, I'm not going to, asthmatic patients that need help. Those aren't the ones we're going to. We're going to people who are struggling with coping in the moment. And it's usually secondary, either behavioral history or something happened in the moment that they're just having a hard time coping. We come in with that lens of, okay, let's talk about what's going on. You validate them. You see, if there's some intervention needed. Are you connected to resources? Like, what in the moment can we do to help you? We have time. We've slowed down. On an ambulance, it was fast. It was, you're in and out. You were getting to the next call. It was just a really fast. You didn't have time to build rapport with people. You didn't have time to really kind of tease out what was actually causing the crisis. And so we have that time. We have those lenses. We have the training. And that's the difference between when police and fire show up versus when we show up. Our lenses are just very different.
What's interesting, though, is, when we look at how much time we do spend on calls, it's probably not that much different than a lot of other first responders, like when we actually average it out. The difference is I don't feel rushed, right? I don't feel rushed to go to the next thing, because we take it from a lens of, we're going to sit here with you and we're going to work through this together in a collaborative way. And we also really take a trauma-informed approach to things. And so we're going to take things at the individual's pace as well. We're not going to rush things or try to force anything. And so having that perspective of, like, I do have time and we're going to go at your pace and we're going to take it from a different lens, a different perspective, more from even like that, more of that medical model too, right? Of like, how can we help you in this moment of, I'm not looking here as a police officer. I would show up and be like, is there a crime? Are you a harm to yourself? Are you a harm to others? Are you gravely disabled? Nope, to all those things. Okay, I gotta go. But now, like, especially with the medical model too, we're looking at, and we look at the whole situation, the whole person, the whole context, and how we can really help them in the moment and provide that space and help them with different interventions, whether it's like a mental health intervention or a medical intervention, simply as just education, right? Providing education about what they're feeling or what they're going through, and like maybe medications, or sometimes just helping someone get their medications, right? Like I've had a long conversation with someone and it was kind of all over the place, and then we're finally able to figure out, oh, the problem is that you just need to get your medication filled. We can help you with that. And so sometimes it's like wading through and like kind of understanding what's going on and then finding the solution. Maybe it's as simple as, I just need my medications, or I just need someone to listen to me, or I just need that connection for a short time.
What I found too is advocacy. Like we just are really able to just advocate for individuals, and we can take the time. And a lot of times, what I see is that they don't advocate for themselves. They're kind of either dismissive of themselves, or they don't know what to ask for yet. And so that's like Jen's saying, slowing down, take the time to talk with them. We can figure that out together. Like, what is it that you need in this moment? And when I was on an ambulance, we didn't have that. It was assess, treat, go. So
kind of expanding on that, you were mentioning having the time to be able to advocate for people. So, one thing I've learned is that you guys will sit with sometimes like hours with people that you are dispatched to see, and you'll even check back like days after with some of these people. So you've already like talked about how important that time is, but like, what are some other things that might allow you to do that other than like just having the time to spend with these people and get to know them and advocate for them and with them?
Knowledge of the community, knowledge of the community resources, and that's something we continue to learn every day. Is we might learn about a new resource in the community, we might learn about a new program, but it's knowledge of the community. So it's again, that's kind of separation between, I think, fire and police and our team, is that we take the time to learn more. We attend meetings, we stay connected with community partners, we go to different fairs, like mental health fairs and different community activities, and we stay engaged, so that when we're working with an individual in crisis, we're familiar with where we can send them to, or who we can connect them to, or the best place to go, and like whatever moment they're in, hey, this service would be really beneficial for you. Are you willing? Like, we can do it together. So it's the knowledge of the community and the resources, I think.
And I think it's also knowledge of what we bring to the table. Like, as a mental health clinician, I bring a whole different set of tools with me now of helping provide de-escalation, right? Or helping, and we have a lot of training and a lot of experience of being calm in really stressful moments. And then as we work through the stressful moment, we can also provide a lot of evidence-based interventions that are therapeutic. And we also base it upon different, having that knowledge, and we're constantly training and looking for how does, interacting with different cultures, right? I mean, Mountain View is very diverse. And so
the most diverse
city, right?
In the country, I think. Yeah,
it is. I think I heard something over 50 different cultures, like just in Mountain View. And so I think that's something we also bring, is an understanding about how mental health and culture is so important, to have that understanding and that respect, and bringing that lens, that cultural lens and that diversity lens, and being respectful of that. So we bring that knowledge with us, with that mental health and culture, and also our interventions, our therapeutic interventions, and we adjust to the individual, right? And letting the individual have, and empowering them, right? Giving that power back to the individual. And I think that, a huge and a way different lens than normal kind of first responder work.
Yeah, and I want to touch one thing on the culture too, is being on this team versus being on ambulance has given me the awareness that I'm maybe not as culturally aware as I could be or should be, but what it's also given me is the confidence to ask, and that it was like kind of an epiphany of like, oh, like I don't know, I'm confused right now about what I'm seeing. Maybe I now have confidence to ask, hey, I'm seeing this, can you help you with this one? And that was being on an ambulance. I didn't ask. It was just let's just go. I don't know what to do. Let's just go. Yeah. And now it's just that confidence is really neat.
How have you seen the emergency services landscape in Anchorage change?
I think we can just reflect back on our data. That is Mike's strength.
Yes. I love the numbers. Yep.
Doing spreadsheets and data. And so we actually created this whole documentation. So every call we go on, everyone we talk to, we document it. And from that, we've been able to collect a lot of really good data about how we are doing. And we also do a consumer satisfaction survey. So we also reach out to individuals and ask, how did we do, right? Like, did we do, like, did we do okay? Were we helpful? Were we respectful, right? We want to make sure we're respectful to everyone. And I know our data shows that we're able to help 83% of the individuals we contact in the past, since we started, stay in the community safely. And that's huge, right? So usually that 83% you can assume is either going to the hospital or maybe eventually even to jail. Like, I don't know. But that many people would not be staying in the community. About 17% are transported by our EMS providers, by AFD, in an ambulance. And then about, I think it was like 2% is transported by AEPD.
Don't hold us to exact numbers.
No,
we don't have them in front of us.
I might be off by a percentage.
We don't have them in front of us, but those are somewhere around that.
Somewhere around that ballpark. And so I think that's huge. And one thing that I know some people have found really helpful, and some feedback we've gotten, is actually when we always ride in the ambulance if we can with the individual when they're being transported, to help provide that warm handoff, and to also help the providers in the ambulance, right? So they can kind of know what's going on, and providing that, advocating for them all the way into the emergency room. And I know a few times when we do transport them, we also try to help create that connection of a discharge plan of like, hey, listen, this is who to contact, this is what can be helpful, here's their providers. And I know some people have been really thankful for that, because it cuts out a lot of the hard work they have to do, like investigating work they have to do at the emergency room to figure those things out. And then we can also I think what we've, the emergency rooms are really overwhelmed. They have, there are a lot of times they're on rotation about what hospital rooms open or closed. And it's kind of hard to say exactly how we've been impacting the emergency rooms all the time. But I do think we have been helping that 83%, stay safely in the community rather than going.
And we haven't done a comprehensive assessment of it, but I think, anecdotally you can say, like Jen said, like these would normally have been all transports. And we're talking, I think, again, don't hold me to the numbers, not in front of me, but we're right around 1,500 911 calls. So 80% of those, 83% of those were about 1,200 calls that got diverted away. That's not hugely impactful to them because they see hundreds a day, but that it is impact. And it is, and these tend to be more complex cases too. These don't tend to be, like I was talking about, an ambulance, I see a breathing problem and I treat it and we transport. Well, these aren't simple situations usually. These are people really struggling and needing an extra hand up. And so the EDs don't often have that time because it's a very fast-paced environment. And so by keeping them in the community and connecting them to resources that are better suited, we're probably seeing reduced recidivism by these same individuals. And again, we haven't done this is all anecdotal. I haven't done an in-depth assessment. We'd love to, and maybe someday soon we will. But like I said, the data kind of speaks for it. And over the last year, we have seen the community embrace the team. So back in August, September, when it first started, we were getting 1 or 2 calls a day. Maybe some days we didn't get any. We would just do a lot of follow-up. And in the last 12 months, we're now averaging 6 911 calls a day and 3 follow-up calls a day. Because like you're talking, we do follow-up. We try to make time for that. But a day like yesterday, we had 9 911 calls and no time for follow-up. So the team is really at its capacity right now as far as what we can respond to each day. But what that tells us is the community's really embraced the team and is really welcoming to this third option for service, And so I would say that would be a one way to measure our impact on the community and the emergency services as well, because those are calls not being handled by PD and fire, but by our team instead.
What led you both to attend UAA?
I did my first year of college out of state and really didn't have a lot of direction. Just did general ed classes, wasn't really sure what I wanted to do. And so made a decision to come home and kind of really reflected on, okay, what is it that I really like to do? And I kind of decided I like to be outside. I like to be doing stuff active, physical. I like exciting things. I skied, played hockey. So I like just being active. And it kind of was driving around one day and I saw some firefighters out. I'm like, well, that could be kind of cool. I'm like, well, how do I find out about this? And so I enrolled with UAA. I enrolled in the I think Introduction to Fire Science class. And so that was in 2001. And so I enrolled in that and had a great instructor. He was a chief at the fire department, AFD here at the fire department. Became a really good mentor, but just seeing the passion that he had for the job and learning about the job, it fit. And I did really well in the class, and I hadn't been doing super well in school because I'd been kind of didn't have direction. And so what I found when I went into that program was that now I had direction. Now I had something to work toward. I really liked the program. I liked the classes, and that drove me to be good at the other general classes. Even though I wasn't super interested, I was like, I'm just happy to be here. I want to get this, and I want to make this part of my career by having this degree. And so that's how I kind of got started at UA, the Fire Science program, or Fire Service Administration program. Yeah.
So I actually did my undergrad in Gonzaga, and I did criminal justice and psychology. And then I became a police officer. When I was a police officer, I actually, in 2011, was in a very major car accident that caused a lot of injuries and a few surgeries. And I finally was able to make it back to full duty. I was really proud of that. However, my body was just really hurting, and it was just hard to keep doing that kind of work every day. And I just was feeling frustrated, and also deciding that I want to go really help people. So I decided to go back to school and get my master's in clinical psychology. And I was looking around at different programs, and I saw what UAA had to offer, and I really looked at the program as a whole, and I thought this is a great fit for me. Like, this is the kind of program that I want to do. And I was really, really happy that I did. I've had some really great mentors here and a lot of really great instructors. And then I also, while I was doing my master's, kind of looked at the PhD program, and I had a lot of encouragement from my advisor, Dr. Eldridge, actually, and a few others of like, you should think about the PhD program. And I was like, no, it's not for me. And then when I was working and I got licensed, I realized I wanted to do more. Like I wanted to keep doing more. And I looked back at the clinical community psychology program here, and I really liked how it included not only that clinical role, but also impacting community as well. And so that's what led me back to UAA again, to work through that program. I'm really happy that I did. I mean, it brought me here, it connected Mike and I, and brought me back into working first responder work in a way that's actually, it feels better, being able to actually, I feel better about it.
So do I, having you. It makes me feel better.
It just makes me feel better.
I recently read the news that you just received funding to expand the mobile crisis team to operate 24/7. Congratulations, by the way.
Thank you.
So what are the plans for expanding the program, if you're able to share?
Yeah. It like all good things, it takes a little bit of time, and so we are currently in the process of that expansion, and there are just several steps that have to happen first, and so we're working on those early steps, and that's through working with the work groups and classifications and getting these positions identified. So it wasn't just as simple as multiplying, because we're expanding the entire program to include additional positions. So we talked about the follow-up. So we'd like to have positions that focus fully on that. We are looking at the firefighters filling more roles and what that looks like with the expansion and the work rules there. So there's a lot of complexities in it because it's a city-run team, so it's integrated in the fire department, and there's a lot of considerations to take. And then we're also looking at the best way to deploy the model. So there's just a lot of factors in place. And so we don't want to just push something forward and have it fail or not be efficient or effective. So we kind of want to do this strategically. And so early on, I talked a lot about phases and phasing things in. And so we're just, that funding was just part of the next phase. So we've kind of got through the early phases of establishing who we are, how we're going to operate, how we integrate with the community. I mean, that's taken a full year to really feel like we're fully integrated. I'm hesitant to even say that, because I still, like you said, you didn't know about it. So I still think there's a lot of room to really fully integrate. So that phase, we're just kind of completing, and now we're entering into the next one. And so, you look at a year of that, we had 6 months to even stand up the team. So it does take time, because we want to do it right. And we want to do it very well and effectively. And it's working. That strategy is working for us, and so we're going to keep that strategy going. So that was just one piece, but it allowed us to get to the next step.
And I think when we are able to get to that next step in 24/7, we definitely want to have some like peak hour teams too. Like if I had $1 million in a dream and could do anything I wanted, we would have multiple teams on at once and some overlap, and someone on all night to respond to crises, at 2 a.m, 4 a.m. And I think I'm excited, and I'm hopeful with time we will get there. And we also have to, something we've talked about from the very beginning too, is providing resiliency and a safe place for our, for everyone who works on our team, because that's so important to prevent any burnout or anything. So that's something we also have to really consider, is how time-wise providing that self-care time and providing that time to create resiliency within the workforce for the mobile crisis team as well.
Yeah, the last thing we want to do is have turnover, burnout, stuff like that. So we want to make sure we're just very cognizant of how we build the team, how we build the schedule, and eliminate that. We want people to work here for 10 years, 15 years. And that's a strategy we take from the fire department. We don't have a lot of turnover at the fire department. We have very little. PD's probably the same way. So we're kind of using that same strategy of saying, okay, no, by keeping people, highly trained people, we're way more effective of a team, and there's a lot more job satisfaction.
I know preventing burnout is incredibly important for people in your line of work, because I forget the term I know you mentioned earlier, Mike, but being that compassionate and being that willing to advocate is just, it's so taxing on people. So
the term compassion fatigue. Yeah, and it's not intentional, right? But what you do is you find yourself, it's in hindsight, you look back and you said, I wasn't my best person at that moment, and I could have been better. And the other thing you got to think about too is when I leave here, or when Jen leaves here, we still have families, and we got to save some for them too.
Right.
You know, so it's really important that we build a program that addresses all that and allows for the success of not only ourselves, but so that we can provide the best product to the community, for lack of a better term.
What advice would you have for anyone who is thinking about pursuing, studying or going into the line of work of mental health and emergency services?
I'm just going to kind of build on what I kind of already started with. Was the advice I would say is I got into the program because it was interesting to me, and that helped me be a better student, and has helped me get the job, and it's helped me be really good at my job. And really, like we built a program within the fire department that had never existed. I couldn't have done that, I don't think, unless I had this education to fall back on. And I think Jen would agree, she's nodding, because she had that education in the mental health world to fall back on and bring that expertise forward. And I had the expertise in the first responder fire department world to bring that forward, and we integrated it. So the success was just loving what I was doing and just having a lot of interest in it and becoming an expert in it and being passionate about it.
I think something that I learned maybe the hard way, which I didn't do, is I didn't reach out to people in the field and ask them first. Because that's something that we did with the mobile crisis team, is we reached out to a bunch of other teams and said, tell me, how did you do this? Yeah. What works for you? What's not working? What did you learn as you're developing the program? And that brought up a lot of ideas for us about how to implement it and how to develop the program. And when I bring it back to myself and discovering what mental health career, I wish I would have done that more in the beginning. Because it's really interesting about the mental health world is so nuanced in what degree you go for, right? Because you have to have a master's degree to become a licensed clinician, and there's different routes that I never knew about. So you can always do your master's in social work, and then you can get work your way through school, and then you get work in clinical world, and you get licensed as a licensed clinical social worker, right? Our other mobile crisis team member, our other clinician, is actually a licensed clinical social worker, and
UAA.
From
UAA. Yep.
So, and then our other perspective is mine, and I'm a licensed professional counselor, so I have an LPC. Technically, we're pretty similar. Our licenses can do similar things. His can do a little bit more. There's a little more flexibility in the state of Alaska. But also, I decided to go the LPC route because that's where I started. And I wish I would have had a conversation with someone about what does that mean? What does an LPC mean versus LCSW? Then there's an LPA, and then there's, what does the PhD mean? And it can be really confusing. I think Mike is just nodding. It is confusing. I think every day I'm okay, Mike, this is what this license means. This is what.
She had to answer a lot of questions from when we first started doing this.
Yeah. And so it's a process to get licensed, and sometimes it can be frustrating and confusing. And I'm glad that I started reaching out to people and just asking questions how do you do this? What steps do I need to take? And I'm so glad I had the professors I did to reach back to and say, tell me how to do this and explain this to me. And they did a really good job of explaining to me while I was in the program. But it's just something I would advise is just talk to somebody in the field, reach out to somebody and ask some questions to see what's the best fit for you.
Jen brings up a great point too, and I guess that's kind of how it worked for me, and without me saying it, was when I went into that introduction to fire science class. That's exactly what it was. It was a fire chief in front of me who we could ask questions to for a whole semester. So like Jen was saying, when I would, for herself, I would in the same way. I was in a classroom setting, I'd learn something, and well, that's really interesting. I'm going to ask after and ask something about this. Is this, what are shifts like? Where do you eat? All these really simple questions, how long is a shift? How many days do you work? I got to ask these throughout the semester to really understand what the job was about, right? And so I think some individuals because you can get hired without a degree, but I think some individuals come into the fire service without a full understanding. And maybe are pleasantly surprised or maybe disappointed. I don't know, but they may not understand exactly what station life is like, what calls we actually go on. We're 80% medical calls. Even though we're a fire department, we do 80% medical. Some people, that's unexpected. We do a lot of work with individuals in crisis in the community. That stuff I didn't even think about. Even running EMS, I was like, wow, I didn't really realize that there was this much impact. So by taking that introductory class, I had that chance to ask those questions, and I knew, okay, yes, this is what I wanted to do. But I'll echo what Jen was saying. In the mental health, behavioral health degrees, it was very complicated as an outsider trying to learn about, okay, what person are we looking for to fill this role? I don't understand. Like, you got to explain that again. You're both licensed, but they're different degrees. There's 4 different degrees we can have to get licensure, and it can be complex. And so that's exactly, I would echo exactly that of reach out. And I'm pretty sure UAA would be a great place to do that, to reach out to advisors and counselors and really ask good questions and make sure that's where you want to be.
How can we help someone that we know who is going through a mental health episode? You're not there yet. So, like, what can we do to kind of de-escalate and help the situation?
I think the most important thing anyone can do is to just be with them, to sit with them. And instead of, I always like to say, instead of providing sympathy, it's empathy, right? And providing that empathy and connecting with someone, and also acknowledging that it's okay to feel uncomfortable sometimes, especially when someone else is really struggling. Sometimes we can feel like a failure because I don't know what to say or I don't know what to do. And you don't have to know what to say or what to do. Just being there and just trying was what's most important. And I think also we also teach mental health first aid. And we became instructors in that to actually provide education to others. And so there are mental health first aid classes out there that actually UAA actually provides to the community. And it can really help provide you with tools of how to ask the hard questions, right? And sometimes the hard question is asking someone, are you thinking about dying? Are you thinking about killing yourself? And it's such an important question to ask to reduce that stigma too. And to say, like, I'm here with you. Like, you're having those thoughts. I'm not gonna shun you. I'm not gonna run away from you. I want you to know that I'm here and I care about you. And I think that's also what's really important, and being able to ask those hard questions. And the more we can ask those questions, the more it reduces that stigma of, I'm scared to ask. Right? And so that's one thing that you can do, is just be present and say, hey, like, I want to help you get some help. And what does that look like? And mental health first aid has a whole thing about how to do that.
Small plug
for it. Exactly. Through UAA. And what it also really talks about as being present is you can always say, hey, like, there's this team, I'd really like to call them for you. Would you meet them with me? They just want to help. And we really want to help people stay in the community, right? Our goal is to help them, meet them where they're at and stay there. And a lot of times people are really scared that we're just going to come and take people away. And that's not our goal at all. And then also people can call and ask us for help too, of like, this is going on in my family. What do I do? We actually have quite a few of those calls where like parents will call or loved ones, significant others, and be like, this is what's happening. I don't know what my resources are. I don't know what to do. Can you help me? And we actually field quite a few of those phone calls and just kind of provide support to the family over the phone first and say, reach out to us, and we're happy to be there in person. But that's a lot of what we also do.
And I would just want to add on the 2 things that I've learned the most to be able to help individuals in crisis or just kind of in a difficult day is the 2 things is active listening and validation. And that active listening is so hard. And I think so many times in our daily lives, when we're having a conversation with somebody, we're thinking about the next thing we want to say, and we're not in the moment with that person. We're not actively listening to what they have to say. And so it's really a conscious effort to say, okay, take a breath, listen, and respond after they talk, and don't talk over them. Allow them to keep talking. And it's amazing at the power of when an individual gets to express their feelings and really get it off their chest, and how positive that can be for them, and how they can almost work it through themselves just by being there, like Jen is saying, present and actively listening, and then validating, saying, yes, that does sound really hard. Not saying, don't say, oh, you shouldn't feel that way. Oh, that's, don't feel that way. Oh, it's just fine. It'll blow over, right? No. Validate it. And then having the confidence, like Jen said, the confidence to ask that hard question. And I didn't have that confidence before getting into even this team, but even prior, early in my fire and EMS career, I didn't really have that confidence to ask that hard question, because then what do I do? They say yes, then what do I do? And now I have that answer. And that answer, there's a lot of resources out there. There's the mobile crisis team through 311. You ask for the team. There's also crisis lines. So 988 is a really easy number to remember now, and that calls a crisis line here in the state of Alaska. And then Jenna, maybe talk a little bit about the psychological services here.
Yeah, so actually, even at UA, there's a psychological, there's the PSC, the Psychological Services Center, that's student run, and that's actually where I got my first experiences and learned so much about providing mental health help. And so the student run clinic here is amazing. It's really low barrier, so we actually refer a lot of people who don't have insurance and who can't afford therapy. I'll refer them to the Psychological Services Center, because it's, whatever you're comfortable with paying, and a really great low barrier place to start with getting therapy and getting help here at UAA.
Jennifer and Michael, thank you so much for being on the podcast today.
Thanks for having us.
Thank you for allowing us to be here and talk about our awesome program.
Seawolf Voices is a production of the University of Alaska Anchorage Office of Advancement and Alumni Relations.